Session 2. Dr. Chandrima Paul she's an FRCS and PhD also in ophthalmology, and she's the director of BBI Foundation Hospital in West Bengal, Kolkata. She is the recipient of DB Chandra Award. She is the recipient of B. Award. She is a faculty at Glaucoma Society of India since 2006. She is the executive member of the Glaucoma Society of India. She was the organizing secretary for GSI Conference of Kolkata in 2007. She is the chief instructor and chairperson and faculty at the World Glaucoma Congress in 2013 and 15. She has been chief instructor at AIUS since 2007 for numerous glaucoma sessions. She has presented many free papers and has done many instruction courses as evaluator also at AIUS and GSI since 2007. She is a reviewer and glaucoma. She is a reviewer and glaucoma subcommittee member of the editorial board of IGO, and she is the executive committee member of the Ophthalmological Society of West Bengal.
So very warm welcome to the postgraduate trainees and everybody watching this program. We are going to share with you, as Dr. Manish has just told you, a few glaucoma interesting cases of diagnosis, how to diagnose glaucoma actually in certain tricky cases. So this is the story of a 52-year-old male who came for a routine examination. He did have a family history of glaucoma. His mother was glaucomatous. And on examination, the best corrected visual acuity was, as you see, 20/20. The intraocular pressure in the right eye was 28 and left eye was 30. The central corneal thickness was 490 microns and 500 microns respectively, and angles were open on gonioscopy. It's not moving. It's not moving, the slide.
It's not changing?
No, it's not going forward.
Maybe you can close it and restart it once more. Or on the lower left side, sometimes we have the buttons to go next and previous. Lower left side, yeah, you can see there.
Yeah, but
button. Can you click the forward button?
No, this just gives the desktop. Okay, one sec. Let me try this here. No, that's also not helping. Yeah, it is. Okay.
Yeah.
It's all right.
So moving to what we saw in the discs after that. So let us look at the discs with suspicion, since we saw that the pressures were high. So if you look at that contour of the cup, this is the right eye, the contour of the cup, and that's the left eye, actually the contour of the cup. The red free pictures are a little bit more clearer. However, the CDR, the cup disc ratio, is less than 0.06, so there's not much of suspect here, and we do not have much of asymmetry either. And if you look at that, the isn't rule, that is the inferior followed by the superior, and then the nasal and temporal quadrants are intact. And the circumlinear vessels, there's not much to appreciate in any of them. RNFL defect, if you look at the red free pictures out there, if you look here, there could be a little bit of a shiny RNFL defect out here, a little bit shiny striations out here, but then the pictures are not as good. So let us move on to see the next lot of investigations. This was automated perimetry. Automated perimetry in the right eye, the glaucoma hemifield test says borderline, and in the left eye it says within normal limits. So that's also not very suggestive of anything out there. And then the OCT was done. If you look at the OCT on your right hand side, you have the retinal nerve fiber layer thinning estimation. That's the peripapillary retinal nerve fiber layer, the right and left eyes. And if you see those pie charts out there, you see a little bit of thinning in the inferior quadrant in both the eyes. And if you look at that graph out there, if the right eye is the straight line and the left eye is the dotted line, then you do see a dipping somewhere around here in the Tisnet graph. And the macular ganglion cell thickness map, that's the one. Actually, the cool colors are where there is loss of retinal nerve fiber layer, and the hotter colors are where it is intact. So we need to correlate this clinical picture with the clinical findings that we have. So this actually I got for you because the Heidelberg actually does not give you the entire ganglion cell complex. So this is the OptiView, which we generally refer to if we are to get a good, if we are to get a good picture of the ganglion cell complex. And there you see there's the thickness map, and I told you about the colors already. Then you get a deviation map as well, according to the loss of retinal nerve, according to the ganglion cell loss around that area. And then you have the significance map, which actually gives you the color coding in that normal green, yellow, borderline, and red. So this is a better report that we get in the OptiView for the ganglion cell complex, but otherwise the Heidelberg is good enough for that. So we label this patient as ocular hypertensive, and the options were only follow-up, frequency of follow-ups, that's the next question, and the treatment. So only follow-ups, considering that this is a patient who had pressures beyond 25 millimeters of mercury, had a family history of glaucoma, so definitely a follow-up is indicated here. And frequency of follow-ups, well, since this was the first and baseline pictures that we had of the disc, the field, and the OCT, maybe we'll call the patient back after, say, 4 to 6 months, depending on, maybe we'll see the pressure once in between, because a single pressure actually does not mean anything. So, and keep the patient on follow-up until we decide on any other treatment. And however, just to say a little bit about the ocular hypertension treatment study that was done, which actually said that 50% of ocular hypertensives actually did not progress to glaucoma, but it also said that those who were treated, actually progression was halted in them. So keeping that in mind, we actually asked this patient to come for follow-up after 4 months. And when he comes after 4 months, we'll again review the whole thing, and then we decide whether we actually need to start him on treatment or not. So that is the first case. So do I move on to the second case, or Manish, there's anything anybody wants to ask or something?
Move on, madam. Till now, we don't have any questions.
Okay.
Anyone who is having question will be able to share the questions on the chat box, and then we can take it in presentation also, or at the end of the presentation also.
Okay. So we move on to the second case. Okay. So for the second case, so this is basically about differentiating between glaucoma and non-glaucoma. So discriminating glaucomatous from non-glaucomatous neuropathy can be a difficult task in clinical practice, and even for an experienced professional. Although glaucoma is the main cause of cupping of the optic disc, but 20% of patients may be misdiagnosed. So if you just look at those optic nerve red herrings that we have, conditions that can be mistaken for glaucoma, they would include the compressive or infiltrative lesions of the optic nerve. Most cases will be pituitary adenomas, craniopharyngiomas, or suprasellar aneurysms or meningiomas. Younger than the average glaucoma patient generally, these people are, and pallor is always excess of cupping. So that's one of the main distinguishing features that you have out there. Like you look here, you actually cannot distinguish the cup very well. It's mainly a pallor that is there on the disc. And just to remember a very, very magic sentence, that is, nothing notches a nerve like glaucoma. So if there's a notch, you can almost say that, you have to look for the glaucoma signs and find them out, because, as I said, nothing notches a nerve like glaucoma. So this is about a 57-year-old male who complained of decreased vision and occasional frontal headache. The visual acuity was 20/30 and 20/200. Both eyes, applanation tonometry was 17 millimeters of mercury. The right eye had minimal pallor of the rim, and the left eye had gross pallor, as you can see out there. We can hardly distinguish anything in the left eye. This was the field. The field is actually placed the other way around. So anyway, the left eye showed advanced field loss, and the right eye actually showed supratemporal quadrantopia, as you see out there. I'm just trying to get this cursor through here that you see out there. And this was actually elsewhere. This was not with us. The earliest available visual field was this one around March 2017 that we got these. And then, but patient actually presented in 2007. We got the history from the patient later on. That is, this is what the patient on repeated questioning actually showed us, that the visual acuity then was 20/30 and left eye PL, and 80 both eyes, 17 millimeters of mercury. The pachymetry was 516. They found grade 1 RAPD and left eye grade 2 RAPD. Both eyes angles were open. There was little nuclear sclerosis, and they actually labeled the disc as 0.6 and 0.9 gross pallor, and labeled it as a progression. So when we saw these pictures, we actually, the first thing that we did was, and the patient was of course treated as a NTG with topical anti-glaucoma drugs. But when we saw this picture, the first thing that we did was we asked for an MRI of the brain with a contrast. And this is what it shows: a very clear, well circumscribed lobulated cellular mass that you see out there, suggestive of pituitary macroadenoma. So superiorly, it was displacing and compressing the optic chiasma. So basically, how do you actually avoid making a mistake like this? That is, you when you get a thorough history, a detailed history, try to ask leading questions to the patient, associated neurological and endocrine symptoms, past medical history, including trauma, excessive low or high blood pressure, prior blood loss or major surgery, and definitely family history of glaucoma is a very important thing. Do a very careful examination with a very open mind. If you have the provision, do the color vision. That could also lead you somewhere. And then scrutinize the optic discs very closely. See whether the patterns are changing. Follow the optic disc. Take a picture so that you have a baseline optic disc picture so that you can compare it when the patient comes after a while. And talk to the patient. Note the speed of progression. Don't rely on a single piece of information. And when you're doing a visual field, it's best to put on the foveal threshold on in such cases so that you know what is actually the foveal threshold. And of course, to check for pallor of the optic nerve, as I told you in the other case as well, cupping should always be more than pallor if it is glaucoma. So the take-home message in this case would be, all that looks like glaucoma may not actually be glaucoma. Neuroimaging plays a very important role in making the correct diagnosis. So this is about distinguishing glaucoma and non-glaucoma. Basically, vascular dysregulation, which happens sometimes, and we mistake it for glaucoma. And I move on to the third case. Manish.
Yes, madam.
Okay. So the third case here is very interesting actually, because is a 36-year-old female from Dimapur. Dimapur actually is in the northeastern part of India. Kohima is the capital of Nagaland, and came to our OPD for a routine eye examination. And on examination, the best corrected visual acuity was 6.6 and 6, and with a correction of, as you see, a hypermetropic correction that was there in the eye. The anterior segment examination was unremarkable, except the Van Herrick's grading of the angle of the anterior chamber, which was a mix of 2 and 1 in both the eyes. And that was the Van Herrick's that we saw. So when you're doing a Van Herrick's, actually, you start from the periphery and then come to the center. And that's the Van Herrick's of this particular patient. I'll come to that again in a moment's time. So that's the Van Herrick's technique that you do. You can grade the Van Herrick's starting from 0 to 10 degrees, 20 degrees, 20 to 35, and 35 to 45. So that's what you actually look at in the Van Herrick's. You make a narrow slit, you cut the cornea into a narrow slit, and then you see the reflection in between. And as you, this is a good picture, because where you can actually see, look at the 0 here with how it becomes wider here, and it becomes wider here, and even more wide out here. Look at that, is the widest, absolutely. So applanation tonometry revealed an intraocular pressure of 18 and 17 millimeters of mercury, and the central corneal thickness was 550 and 542. That is what we saw on gonioscopy. So the gonioscopy actually revealed a mix of Sheffer's grade 1 and 2 in both the eyes, and just to recapitulate a little bit. So these are the structures that we see on gonioscopy. If you look at it, the Schwalb's line followed by the trabecular meshwork. The trabecular meshwork has two parts, the anterior and the posterior. Then you see the scleral spur and the ciliary body band finally. This I find is a very nice picture, where this is exactly how we see when we are doing indirect gonioscopy at the slit lamp, and the trabecular meshwork is generally seen as a pigmented band out here, and that's your scleral spur, and finally the root of the iris. So when you're doing gonioscopy, this is since it's a webinar for the postgraduate trainees, you must train yourself to actually start straight away with the 4-mirror gonioscope, because that would actually help you to do an indentation. So as you see out here, when you do a gonioscopy, and if there is an appositional closure, you need to find out whether that is actually appositional or synechial closure, and for that you need to do indentation. So it's the 4-mirror with which you can only do indentation. And as you see out here, look at this, the appositional closure, when you indent it, what happens, and similarly a synechial closure, when you indent it, what happens. So start training yourself to use the 4-mirror gonioscope, the Zeiss or the Sussman, whichever one is available or you're comfortable with. With this, we move on to that's the anterior segment OCT of the same patient, and that's where you see that the angle opening distance is narrow. So that's the ultrasound biomicroscopy that we did, the angle with the narrow entry, as you see, and here's the peripheral anterior synechial. This I just got to show you so that you understand the difference. And this is, before we give pilocarpine. Once we give pilocarpine and the iris falls back, this is what you see, and this is a post-YAG PI that you see in the UBM, in the ultrasound biomicroscopy. So just a little bit about the Sheffer's grading. The Sheffer's grading starts with 0 when the Schwalb's line is not visible, with 1 where the Schwalb's line is visible, finally 2 and anterior trabecular meshwork visible, 3 is when you can see the scleral spur, and 4th is when you can see the ciliary band. There are actually a number of systems of grading that we have for the angle of the anterior chamber, but one of the easiest to follow in day-to-day practice is the Sheffer's system. But for your examinations, you'll have to know the Shees and the Spates and even the Madan Mohan's classification. You'd have to know all of them, but this is, I suppose, the easiest to follow. Coming to the VCDR, that's the vertical cup disc ratio. This was absolutely unremarkable because it's just a 0.45 or so, and how you calculate it, I have told you the other day, but for the benefit of those who are attending for the first time today, that you take this as 1, and then you actually minus this part, whatever you think, say it's 15, say 0.15 or 0.20 from 1, and that's how you get the cup, what it is. So she was advised to undergo laser peripheral iridotomy in both the eyes and was subsequently put on a 6-monthly follow-up. So this is basically a patient of primary angle closure disease. So the take-home message for this would be certain ethnic tribes from the northeast of India are more susceptible to angle closure disease. Major risk factors for angle closure disease include age, female gender, ocular biometric features like hypermetropia, and ethnicity, as I just said. And you also have around the world Africans, Chinese, and Eskimos, who actually also fall into that category. So that's the end of the 3rd case.
Yeah, thank you, madam. Now we don't have any questions, so I just thought for clarification for the PGs, one point you were mentioning about the neuroimaging.
Yeah.
So we do get a lot of patients with pallor and atypical field defects. So what are the criteria you look into disc or for perimetry where you consider neuroimaging? So in your glaucoma practice, which patient you think needs a neuroimaging?
Yeah, actually, neuroimaging I generally do for all my patients who I think are NTG, normal tension glaucoma, where there is a cupping and maybe there's a field defect as well, but then, they have low pressures. So I really can't label them as glaucoma, primary open angle glaucoma, but then there are many other differential diagnoses which one has to exclude, but definitely neuroimaging is a part of normal tension glaucoma. You have to rule out that there is no vascular factor which is causing the cupping basically. So that's generally where I advise neuroimaging in normal tension glaucoma.
Grading. How do you grade RAPD?
RAPD, actually, you have to, the rapid afferent pupillary defect, there are the grades which I did not describe out here, show out here, because I thought that, you know, it's a total theory. So they can just read it up and, you know, instead of saying it in detail out here, basically.
Ma'am, one more thing, we also discussed about UBM. So we do get a lot of angle closure patients, even open angle and secondary glaucoma. So which cases you find UBM and ASOCT useful?
Yeah, UBM, I think, Manish, as far as I know, you do more UBMs than I do. But UBMs, I actually do only for my plateau irises. I don't do UBM on a routine basis. When I doubt that there is a plateau iris syndrome or a plateau iris configuration, that's when actually I, you know, do a UBM or send the patient for an UBM. And UBM is most helpful when you're actually trying to diagnose that the patient has a plateau iris syndrome. And I restrict it totally to that actually for UBM.
Sure. I think what you were also highlighting that 4-mirror gonioscopy is very important, and most of these glaucoma patients we can very well assess the angle based on gonioscopy. UBM and ASOCT, as mentioned, are useful for certain specific cases. Like for example, plateau iris definitely. Few patients, madam, like malignant glaucoma are also useful. Drug-induced glaucoma. I think you have another case on drug-induced glaucoma. In these cases, UBM could be useful. I think we can go ahead with the next case. Till then, if we get any questions, we'll take them.
Sure.
Okay, thank you.
Okay, so this is the story of a 37-year-old male experienced acute onset blurry vision and ocular pain in both the eyes, and on examination gave a history of having taken tablet topiramate for suspected migraine for the last 4 days. The family history was significant for cataracts and retinal detachment, but no glaucoma. There was corneal edema, both eyes, and Van Herrick's grade 1. IOP was 60 millimeters of mercury in the right eye and 34 millimeters in the left eye. So initial diagnosis of bilateral acute attack of the angle closure disease was made, but it's very, very rare to find a bilateral acute attack. But then we couldn't see anything further because of the hazy corneas. So we thought, let us first start the treatment and then we would investigate further. So we treated with oral acetazolamide, 1 tablet 4 times a day, topical timolol and brimonidine combination twice daily, and along with discontinuation of the topiramate tablet. The next morning when the patient came, the uncorrected visual acuity was 20 by 400 OU. The manifest refraction was -5 and 1 cylinder, and the right eye it was -4.5 and 1 cylinder. The best corrected visual acuity then was 2032 OD and 2040 OS. The IOPs were 9 millimeters of mercury and 11 millimeters of mercury. Slit lamp examination revealed mild corneal edema, marked shallow anterior chambers without any inflammation in either eyes, and gonioscopy revealed grade 0 angles on Schaeffer's classification. Undilated fundus examination revealed that macula and optic disc were unremarkable. So the UBM actually confirmed the 360-degree ciliocoroidal effusion and anterior rotation of the iris processes with the forward displacement of the lens iris diaphragm, as you see out there. That's the effusion that you see out there. And ciliocoroidal effusion from the scleral spot detached detachment of the ciliary body and an anterior rotation of the ciliary process in the right and the left eyes, both of them that you see out there. This is the picture that we got when we did an UBM. And then a diagnosis of topiramate-induced acute angle closure disease was established. He was treated with topical prednisolone acetate and cycloplegic agents. 3 days later, when we saw him, his vision was 20/20. The ACs were deep and the IOP was 10 millimeters of mercury. The spherical refraction of both the eyes also improved from -0.5 to almost -0.5. And gonioscopy revealed grade 4 angles by Sheffner's classification. So the UBM revealed that the annular ciliocoroidal effusion had resolved in both the eyes. If you look out there and if you compare with the previous picture, and on day 15 when we saw the patient, showed resolution of the ciliocoroidal effusion and deepening of the anterior chamber in both eyes. So anti-glaucoma medications, corticosteroid and cycloplegic eye drops were subsequently discontinued. And a little bit of discussion, bilateral acute angle closure disease, ciliocoroidal effusion and transient myopia may be induced by drugs such as topiramate and some other drugs like anticholinergics, which are used for irritable bowel and all that quite often nowadays. And the proposed mechanism of myopia and secondary angle closure is choroidal effusion and forward rotation of the lens iris diaphragm. The effusion places pressure on the vitreous body and presses the lens iris diaphragm forward, causing anterior displacement and closure of the angle. The treatment for topiramate-induced secondary angle closure are cycloplegia and topical corticosteroids. Cycloplegia relaxes the ciliary body and tightens the zonules, keeping the lens iris diaphragm in check. And most cases of topiramate-associated angle closure glaucoma present within the first 2 weeks of treatment, but reactions have been reported within hours of the first dose or as long as 7 weeks after onset. So that actually finishes the drug-induced glaucoma part of it.